सुरु गरौँ।
Namaste and good evening, everyone. On behalf of GOSON, Gynae-Oncology Society of Nepal, we would like to welcome you all on this very important event. We will be discussing on cervical cancer, its prevention, and of course, some of the colposcopic evaluation and findings. On behalf of GOSON, I would like to welcome you all. And today we have GOSON executive and general members with us. And we have NESOG members with us. And we have MESON members with us, all the respected ones, the members, seniors. And today, to begin the program, on behalf of GOSON, as a General Secretary of GOSON, I would like to kindly invite and request Dr. Sheila Burma, President of GOSON, to chair the session. And I would like to invite her to begin the session with welcome note and introducing our distinguished speaker, Dr. Sarita Ghimire, our senior, who has contributed a lot in the field of oncology in Nepal. Sheila ma'am.
Thank you, Dr. Jitendra, for your kind words. Good evening and namaste. It's my pleasure to welcome you all on cervical cancer screening colposcopic skepticism webinar organized by GOSON. GOSON was established in 2017. From its inception, GOSON has been conducting various academic programs in the field of gynecological oncology. There are some glimpses of the GOSON activities on the screen. I am very happy to introduce Dr. Sarita Ghimire, today's speaker. She is a senior consultant gynecological oncology. At present, she is the chief of Cancer Screening Center and Nepal Cancer Care Foundation. At present, she is national expert of scaling up and strengthening cervical cancer screening and prevention program 2021 for Family Welfare Division, Ministry of Health, in support of WHO Nepal. She is trainer and coordinator, National Health Training Center, Cervical Cancer Screening and Prevention Training Program, as well as she is a coordinator, consultant, trainer for Hpv Gavi demonstration project for cervical cancer prevention program in Nepal. In 2018, she was consultant, coordinator, NSTC, Health Ministry, Government of Nepal, and WHO for the revision and development of training modules of cervical cancer screening and prevention program Nepal. From 2016-2020, she was consultant, Health Ministry, Government of Nepal, and UNFPA for the development of implementation plan for cervical cancer screening and management in Nepal. From 2013 to 15, she was expert consultant, WHO, CERO, for the development of training modules for comprehensive cervical cancer control in Southeast Asia. 2015, she worked as an international resource faculty for testing of training modules on cervical cancer screening and management. 2014 to 15, she worked as a consultant coordinator for development of reference training manual for cervical cancer screening program in Nepal for Family Health Division, Ministry of Health in support of WHO Nepal. 2018 to 14, she was Associate Professor, Department of Obstetrics and Gynecology, KIST Medical College. 2008 to 13, Head of the Department, Department of Gynecological Oncology, Bhaktapur Cancer Hospital. 2014 to 8, she was Registrar, BP Koirala Memorial Cancer Hospital. She worked as an expert technical working group on developing national guideline of cervical cancer screening and prevention in Nepal for Family Health Division and WHO 2010. She has various publications, national and international journal. Thank you, Sarita, for accepting our invitation. Now I hand over to Dr. Jitendra to continue the program. Thank you very much.
Thank you, Madam President. I would kindly like to request Dr. Sarita Gimire, consultant gyne-oncologist, and I am proud to say that she was my senior and she will always remain as my guide in the field of oncology to make her deliberations. And I will be moderating this session, and we will have question answer session or comments after the presentation. So kindly you can send us your questions and comments in the chat box also. Sarita Madam, your presentation, please.
Thank you very much, Dr. Jitendra. In the meantime, while I'll try to share this screen, I'll be talking. Thank you very much, GOSON. Sila ma'am, basically, she has made me obliged actually. She has requested so many times, many times, I'm really sorry, ma'am, but for this opportunity, I'm really thankful to you and GOSON and Jitendra, everyone. This is my pleasure as well. So, I'd be delighted. My screen share boy, is my screen is on the...
Yes, ma'am. Screen share bhayera ma'am. तर disturbance आइरहेछ ma'am को side mic actually mute गरेर फेरि unmute गरिदिन्छु please. Some kind of disturbance के computer को fan को आवाज or something like that. Now it's okay. Please on गर्नुहोस् त ma'am. फेरि actually फेरि आएछ. Some kind of fan को आवाज or something like that.
कम्प्युटर को फ्यान को आवाज हो अरु त के पनि छैन यहाँ
अहिलेसम्म आएको थिएन भर्खर एकछिन देखि अहिले फेरि गयो फेरि आइरहेछ
अलिकति पुरानो भयो भन्ने लाग्छ
अलिकति ठुलो स्वरमा अहिले गयो अलि सानो गरे ठुलो गरे
Once again, thank you very much, GOSON, my respected seniors.
Excuse me, ma'am, अलिकति ठुलो स्वरमा है साउन्ड अलिकति किनभने त्यो ब्याकग्राउन्ड त्यो डिस्टर्बेन्सले अलिकति साउन्ड सानो आइरहेछ प्लिज म्याम प्लिज क्यारी अन सरी
Thank you very much, Debesi. Respected seniors, my colleague, my juniors, and everyone, thank you very much once again for the GOSON and everyone involved with this. I'm delighted to share a few of the knowledge I have gained through my working in this cervical cancer screening, especially Western Nepal, and colposcopic skepticism. I have kept a little bit difficult name, just thinking rather than putting it just as a confusion, I'm trying to get the attention of everyone. That's the only reason. So, so with this presentation, I'll be talking on cervical cancer before going to the general be complete. So few of the things about cervical cancer. Then what could be the screening method that they are available in right now? What are the methods available in Nepal and how we can utilize maximum of that for the maximum benefit of the people? In another word, the best model if we can propose any. And then colposcopic basics for good report, basically, not to miss the diagnosis. So human papilloma virus, this picture we can get nowadays for coronavirus as well everywhere. I'm not going in detail about it. And even for the natural disease spectrum also, the natural history of the cervical cancer, we all know that Spv virus, when it goes inside the cells, it affects in the nuclear line of the cells and different changes comes over there. We are all aware and how it makes the changes. With these different changes from first picture where we can see a normal cervix to develop the cancer, it takes 15 to 20 years. It is not a new thing to us. We all know that. And then different cellular changes it makes in between is in the middle line. So coming to the statistics, basically whenever we talk about cervical, any of the cancer statistics, I always say we are underestimating because unless we get a population-based cancer registry from all the 77 districts, we are nowhere. But still, whatever comes in hospital statistics, we have seen that 15 to 49 years of age group in the woman, it is the most common cancer, no doubt. And if you look at the screening, which has been the recent published NSRC NCD STEP survey, where they have found that 8.2, its coverage is very low, but it was published in 2019, though done in 2018. So we can expect that now it must be more than this, but anyway, it's still very less. So coming to the Nepal in the GloboCan picture, if we see, again, cervical cancer is in the very highest after the lung cancer. We can see the number somewhere around 2244. It is there, which has been published in 2020 by the GloboCan. Similar picture, if we look at the publications from BPKMCH Bulletin, or that another publications was from 12 hospitals. They have done a hospital-based statistics. It has been, as a cancer registry, hospital-based cancer registry, it has been taken from 2013 to 15. So it has been somewhere around 25, 52, even more than few cases has been more than this in another literature I have found, but I didn't mention. So risk factors, we all know that. I'm not going on that. The only thing is, if there is a persistent HPV infection, we can never forget that. Now coming to the prevention, we all know that cervical cancer is the topmost. It is the only cancer that we can prevent almost completely. If we see, though in breast cancer we say not prevention but early detection, cervical cancer is one of the most preventable, and that is one of the most commonest in women we have seen with the statistics. And we know 30% of any cancer, either these or any other, are easily preventable by simple changes. Either we say lifestyle modification or simple screening and examination, or our dietary factors, all these affect for the prevention of cancer. This slide, I find it quite interesting. I just want to show this because it has been proposed by WHO that will control by 2030 elimination of the cervical cancer. We are also included, including us. It is not only for the developed countries. But if you look at current status, are we really going to achieve this 90% vaccination? Because after 16 and 17 government national vaccination program, we couldn't upgrade from the demonstration project. We are still fighting to upgrade to that to national program for the vaccination thing. And 70% screening. We can see in the 2019 data that only 8.2, maybe slightly more than that, but still covering the 70% of the whole population where we are really. And 90% treatment, maybe that we can, because a lot of private hospitals and other centers opening, maybe in the treatment portion, this 90% we can assume to achieve. But these two things I really doubting unless we, all of us, start acting on this and government more serious about the elimination project. Otherwise, it won't be this thing achievable by 2030. I just want to show this cost effectiveness. I have found in one of the study done by Lynette Denny published in 2013. It's of India, though it's not our country, but as we are very similar, India and Nepal, all the context is quite similar with cervical cancer. Even in their context, it's very high. This picture, we can see that first two lines, 40 millions and 180 millions, is just when there is a vaccination, and it comes with the screening cost. But it shows very interesting projection that till 2020 to 2050, up to 2050, there won't be any decrease in the cost. Even we started the same prevention program right now from today, in going with all these 70% and 90% statistics. And even it was almost similar that fourth line, 15.6 billion, is for where no prevention was initiated, only for the treatment cost. It is coming same by up to 2050. But if we look after the 2050 up to 2080 in this picture, we can clearly see that the cost reduction is almost half. We can say 9.8 billion from 15.9 billion it will come. So we really, from the health policymakers, I really feel we should start working on this, because cervical cancer, with our laws and our expenditure at present, this we need to work for our daughters. It's not for us. We can see clearly up to 2050 it is not going, even up to only at the 2080 it is going down. So talking about the elimination, we have already come across screening and Spv vaccination, no doubt. With the screening, a few things I know all of us are very much aware about Spv DNA, single visit, cytology. I'm not talking much about the cytology because I have a few reservations on the cytology, what we are doing without quality assurance in our setup. So with the Spv DNA test, it is well proven that it is the most effective screening. Even WHO has in their recent guideline, they have said it is as a high precision test, it has been taken, is the only one rather than cytology and VIA. So again, in the second line is a self-sampling test. It is basically for the difficult terrain where right now we couldn't cover it. Our coverage is reaching only 8.2. Sadly, I have to admit that from 2010, we developed a national reference guideline. Then from 2011, we started training the hospital staffs, either doctor or nursing staffs, for this VIA training. But still at till 2018, our coverage is coming only 8.2%. So it's really high time. We should think that how we can make it more in a larger scale and more approachable. If you talk about the Spv DNA, we all know that it is highly sensitive. Almost all the literatures are full of its comparison with cytology, VIA, and Spv DNA test. So it's a highly sensitive. And self-sampling is possible. It has been well proved now that we don't need any medical person to collect the sample also. Even the same brush we can use, and a woman can collect the sample. And best for the low resource country like ours, where we want to reduce our cost. We are spending so much, even in the India cost, even if it is half, that is very much for us. Similarly, it reduces the health burden of the health manpower, and PCR based and hybrid is up level, and quality control is even more manageable if we really try to do in a Spv test. Only at one point is more effective rather than cytology, where we have to control at 4 or 5 spots for the cytological test. So initially, it might seem that Spv DNA is very high costly, but in a long run, for the country benefit, for the woman's benefit, it's definitely going to be simple. Now, talking about the single visit approach, now it's with as I've said, in 2010, we included it in our national guideline. Then from 2011, we started a training program, and it has reached almost all the districts right now, though it's in a piecemeal manner, but everyone has heard about VIA test more or less. And it is because why it has gained so much of popularity. Even in other countries, it's very simple test. Immediate result is there, and it can be treated, especially for the developing countries where we can't afford 2 visits. Is the best one. This one I really like to share with all of us, that It was a cluster randomized trial done by Shankar Narayan. He started enrolling the eligible women of 30 to 49 years in 1999, and study formally started in January 2000, and they concluded after follow-up in 2007, December 2007. So this 4 variables he has compared: SPV test, cytology, VIA, and control group, where 31,488 standard care was given, but no screening method, unless later on their follow-up when specifically asked for screening or they demand, then only it was done. Otherwise, they were just a control group. It's a very large study, one of a very large study it has been published till now. So it has been found that positivity rate, if you look just simply in this chart, is that with the HPV test, it is 10%, whereas with the VI, it is somewhere around 13.9. Even with the cytology, it is not that less as we have found in other studies. What I personally found is this was all done in one project, and all the health staffs, all quality assurance was fully maintained throughout the from workers were trained for 4 weeks. Intensive training was given to all of them. So with the positivity rate, we can see our VIA test is not inferior at all. What we are doing right now is, it is 6.1% positivity, but this positivity is slightly lesser when we talk, because it was for CIN1 reason. When we talk about CIN2 and 3, SPV has come out, though I have combined all the results in one go, which is statistically significant also. And in the 4th line, cancer death was, if you look at the hazard ratio, SPV testing, it is 0.52, whereas in the control group, it is 1. And in this cytology and VIA, when it was compared, statistically, it was seen that hazard ratio was in the HPV test, it was significantly lower than these 3 groups. That's why I'm saying, in the long run, with the money, if we talk financial or we talk about the cancer death also, it's going to come out very effectively. That's why I said in my previous slide also, orange is more effective if in a low resource setup like ours. So it's a visual inspection. I'm talking as with the continuation that I put 2 pictures just to make us remind that these are the same pictures we are going to get in the colposcope also. So I'm not in say that we should obsolete VIA test or we should be doing. This is one of the best tests. We can even see from that last trial that it has proven his efficacy. No doubt, and its simplicity has made us very much easy to take. But again, in a country like ours, 2011 to coming to 2021, what I personally feel from the very beginning, I'm as a trainer, as a developer of this training program and everything, what I personally feel is with the now training is going, all the provinces are taking it very nicely, all has more or less allocated some amount of training budgets over there. But when we talk about the trained manpower, whenever I visit any of the health centers, there's always a scarcity of the person to do a VIA test. So how we are going to overcome that is going to be a very big question mark for us for this 10 years of our this training duration. And another is quality assurance. Still, we couldn't have worked much on VIA quality assurance, which we are talking against cytology because we couldn't do much on the quality assurance in that cytology test. The same thing is coming with our VIA testing now. If we look at the impact of the screening till date is, yes, no doubt, VIA is well heard and accepted method. Nowhere in a community female has said, I have some problem with VIA test or anything like that. They are easily accepted, this thing. So, but if we talk about increasing coverage, right now, if we say our coverage is low, we need to tackle our quality assurance issue along with the coverage. And if you look at the Nepal experience of vaccinating the daughter and screening the mother, it has come out to be very effective in those 2 districts which we did in 2016 and 17 from the Gavi demonstration project, where it was only the 2 districts has been covered. but it has gone very nicely. And this double approach, I'm sure we will all think about it to make it. Now, coming to the Spv vaccinations, it's 2 doses administration is over there. If you look at the fact published in Lancet in 2019, it was a meta-analysis from 2007. Vaccination has been adopted by many of the countries, and collecting all 60 million population of those vaccinated population, it has been done. And it clearly shows that 83% among girls were protected, decreased. There's a 83% decrease in the HPV 16 and 18 infection, as well as cervical pre-cancer decreases somewhere around 51%. It's more than 50%. So no doubt vaccination is effective if we can give it, upscale it for the national level. These are the market available things. I just Google detail images. And this monovalent, which has recently come. But why I put these pictures is that we shouldn't forget one of the, I haven't put a link to that, but I can provide. One of the Nordic country, that's from the Sweden, they have published their cancer registry, this thing, where pre-cancer also they are registering in the cancer registry system. From there, it has been seen that after vaccination or whatever, whichever cancer they have registered, it is not other than 16 and 18. The cancer causing is other viruses which has been included in this monovalent. Still, though we always term that at a high risk, but ultimately, if we talk which virus causes the cancer is always coming back, falling back to 16 and 18. So even if we get just a Cervavax bivalent vaccine, we should be happy that we are protecting our daughters rather than asking for something higher. This, with the vaccination 2 doses, we all know that initially it was 1 dose, now 3 doses, but now it is 2 doses. I put this one, another study findings where it has been shown that if we are aware, this vaccination program has been started in India at the same time in other countries in 2007. But due to some scandals, if any of us still remember that, it was in a lot of newspaper at that time. After vaccination, 2 girls died immediately after vaccination. So they made a big propaganda, and that program has been withdrawn at that time. And those 1 shot girls who couldn't take a second shot, somewhere around 4,000 plus girls were there. This study was done and published in 2018. They were compared with other cohort of the same strata, where girls has been received 2 doses or 3 doses, and it has been seen that the effect of 1 dose, 2 dose, or 3 doses are exactly similar. It is not different at all. So even if we can vaccinate our girls once, also we should be happy. Even 2 doses are whether really necessary or not, it's going to come as a big question mark. So what we need to do is SPV screening is the SPV vaccination and awareness, no doubt, but where we are, we just jump to VIA. We missed that first vaccination step. And the second step, we are looking up with the SPV test, but whether we have to come down or to go up, we are in middle. We are just stuck, though we can say it is a good start, but we really need to do more if we are thinking of elimination as a whole world is thinking. This is a VIA testing, what we are doing right now with the national protocol, our national guideline. 3 to 5 years now, WHO has recently revised this. So I have made it 3 to 5 years. With the VIA, they are again revising not a 5 years, but it should be in a 3 years. Although is similar, if lesion is there, treat with thermocoagulation eligible, not eligible, plan for LEAP or to the higher center if suspicious of cancer. But this, I put a second picture is for the SPV testing. It is for 2 kinds. One is simple SPV test, either positive, high risk, positive or negative test we can get. Another is DNA. It's called a high precision test. In a DNA, we look for 16 and 18 only also. So either of any of these SPV test and VIA is not away from us. VIA is there in the second portion. With the SPV test, we really need this VIA trials. So for a country like ours, we can easily adapt, which they have recommended is in 2021. And I was one of the members for the external review group for this guideline. It has been recently published. So VIA trials with photography or colposcopy, that's upcoming. Again, we can go follow the same maneuver in our setup also. Now coming to what will be the national goal we should make is, obviously we should focus on the larger area, no doubt, slowly shifting to self-sampling HPV DNA. This no other options we have, though we will do it from tomorrow or after 5 years, it depends, but there's no other options other than going to HPV DNA. And VIA trained health workers. We made this, we have to continue with the training, but we are reserving them for those SPV positive. This means our patient will be very few, their burden will be very few health manpowers. Even for their retention, we don't have a problem like we are experiencing right now. So treatment when and where necessary, cold coagulation is well accepted now in Nepal also, and it is easily available in the market, this instrument in low cost, so we can use that. Vaccination program, I'm not talking much. Procurement is a big problem. Till now, we are fighting with the national operating. This VIA result, I just put it because from this slide, I'm shifting to the colposcopy. So what I really feel is doing VIA test since 2011. It's now 10 years I have completed. With the VIA, if eyes are well trained for the VIA, 70% of the colposcopy work is done. We don't need a colposcope. That's only for the 30%. I'll come few of the confusions where it really gives us a problem. There we need a colposcopy. Other than that, just for the 70% of the cases, if we are trained in VIA, if our eyes are trained in the VIA test, then we don't need a colposcopy. This is just a picture, just to point out that though this, I have taken it from my colposcope to take a picture, I have used the same machine, but it is almost similar. Whenever I take from my mobile phone, it comes the same. Now coming to the colposcopy examination, the picture come in this second picture is from our study time when I was doing my medical school graduation. It was there in IOM. I have seen this, and this now the first picture is computer-directed colposcopy, where we are almost many centers are having right now this, and we whenever colposcopy comes in mind, we don't forget this biopsy forceps, and we really tried our hard best to learn its spelling. Tissless biopsy forceps as a gold standard, and then the cervical, this cervix picture, where we are trying to find those white patches if you can see through the colposcope and this. So coming about the colposcopy, before going to this picture, anything comes abnormal. Either pap smear test is abnormal, either VIA test is positive, or Spv DNA is positive. Then we do a colposcopy test. But recently published ACCP recommendation, it has been published in this in 2017. It's a systematic literature review they have done of 10 years. There they have pointed out few limitations where literally accuracy and reproducibility of the colposcopy are limited. And they have pointed out what are the factors, like standardized terminology, the use of, in this meta-analysis, whatever has published in the colposcopy, it has been found with all the either gynecologist has published or gynecologist, anyone. This lack of standardized terminology is there. Similarly, recommended for colposcopy practice and procedures is also lacking behind. What exactly is there? No one is following. And the third is quality assurance. It's coming everywhere. Even in the colposcopy, it is the same thing. So they have recommended strongly that it should be used as a risk assessment tool. Though we said we have learned it is a diagnostic tool, but it's not a gold standard diagnosis. We all know that biopsy is a gold standard, but we are using it as a diagnostic to risk assessment, not exactly to focus ourselves on it. It will give us an accurate diagnosis and will be based totally on the colposcopic examination that has been come out through this study. In the same study, they have said that also, and we are using a little bit of terminology which nowadays we are trying to stick to, is like general assessment. In the general assessment, we talk either about satisfactory or unsatisfactory, or adequate or inadequate. We have to understand this terminology is basically for the visualization of the cervix. Okay, not my impression whether this is good or not good, but it is basically whether I can see the cervix or not. This general assessment is for that, because I've seen a lot of confusion, especially our postgraduate students and early beginners for the colposcopy. And then it has been clearly mentioned through the transformation zone visibility. Either we can classify it as 1, 2, 3. We all know one is where squamocolumnar junction is just in front of our eyes. I'll show the pictures of them where it is very clearly seen. Or second, where we need to do some manipulation, but with simple manipulation we can see. And third is like we can't see even with some manipulation. Or we can simply say it is fully visible or not. It has been made very simply, but we have to follow this according to this recommendation, which I have found also quite useful for us when we are doing colposcopy, and it's easy also. Then acetoid changes, we'll come to a lot of other findings in the acetoid changes. And grading of the lesion, not to forget, we have to grade. If we are doing a colposcopy, we have to grade the lesion, and we have to clearly identify acetoid area. Many of the times, what we do is, okay, this is my feeling, this is not a normal colposcopy, but what is the findings? We have to base on this terminology as well. Which one is not actually not coming to our exact assessment? We have to be clear. And they have pointed the scoring system also. And they have very rightly said, though, in the beginning days of my medical school, I have learned about the REACH scoring, which at that time it was in use. Now it is, it has more or less, many of us has shifted to Swedish scoring. But whatever scoring it has been used in that systematic review, they have found that there's no evidence of these formal scoring systems actually inconsistent for predicting high-grade disease beyond the subjective assessment. It has been with this literature, there are nurse colposcopist, gyne-oncologist, medical doctors are there, all short of this thing. Our health workers were there in this study. And with the miscellaneous finding, any other findings are in the vagina that could have been easily identified even without a colposcope. But with all this thing, I'm not saying for that 30%, especially as we are a gynecologist, a lot of us are practicing gyne-oncology. We need to know how to do colposcopy and how to reporting, there's no doubt. Now, if we talk about the reporting, this is a very important thing. If we are a beginner, we can print this and always hang in our colposcope machine. That's a very easy thing I have seen at my initial days of practice when I went to BP Koirala Memorial Cancer Hospital. At that time, nursing staff were trained to do a colposcopy as well. So in this read score, they have hanged in the colposcope. I found that very easy whenever, because most thing I had, it was already out of my mind after my postgraduate. So it was over there, like cervix visibility, we have to mention the factors are given. What are the things to mention? It has been there. With squamocolumnar junction, definitely we have to say how it is, acetowidening, whether present or not, lesions, whether present, the lesions we have to mention. Similarly, locations of the lesion, we have to see if we are taking, nowadays I have seen many colposcopy report I'm looking after, which but in the descriptions, these things are lacking. So I think we have to change. This is a comprehensive list, and if we are very busy practitioner, what I can do, I can suggest is the minimum criteria. At these 4 things we can always. Is fully visualized or not fully visualized? Whether it is present or not, and then lesions present, either acetoid or any other, and then colposcopic impressions. Please do not forget whatever, especially for the early beginners and my postgraduate students, if they are in this presentation. We shouldn't forget to write a colposcopic impressions. It's normal, benign, low grade, high grade, or suspicious of cancer. This. I have just made it very simplified for us for the busy practice. If we can't put a comprehensive list. So we have talked a lot about the squamocolumnar junction. This picture we have seen since 2002, published IARC manual. Dr. Shankar Narayan has put a lot of effort to draw this picture at the time, but still I'm using his permission from his manual that This is how we see a transformation zone and squamocolumnar junction. So if you look at the picture, this is the first picture where we can see a squamocolumnar junction protruding us. And second picture is with the term sepate. It's metaplasia is in the process. And if you look at the third picture, it's coming that squamous metaplasia is more or less. It has almost that cervix, and in the last picture, squamous metaplasia is there along with few prominent vasculatures is there, but this is not VIA positive. I have to say this is with acetic acid. This last picture is. So in the post-menopausal, this is the cervix. We can see thin out cervical epithelium with this polyp, small reddish polyp in the center with a lot of vessels around. And if you look at the same picture when we applied acetic acid and visualized through the colposcopy, this thing has taken some whiteness, and even with our simple test, there's some petechial hemorrhage has started. And third one is with the local side. So, talking to the vasculature, this is about the squamocolumnar junction, where in the postmenopausal it has gone inside, and in the perimenopausal before that, in the young reproductive age group, it is out. With the vasculature, a lot of things are there in the book. But when we really look in the picture, it is always difficult for me. Even if you ask me to show the abnormal vessels, it's most of the time very difficult. All these normal vasculatures in this picture, which I have reproduced from that reference manual, which I managed to hand over to WHO in 2015. So these are the normal capillaries and normal branching pattern they said, but when we see it is in the picture, this is usually we find this kind of things. It is not exactly in this picture where to fit this first picture or this second picture, I don't know, both are normal. Both are basically very normal pictures, but how to fit this in this picture is always difficult. It is, that's why in the SSCP recommendation, I fully agreed with them, is most of the time subjective assessment is very much in colposcopic examination. So this third picture, definitely, this is not a normal cervix. I'm going to show another picture of this after acetic acid. This is without acetic acid, only normal saline has been applied, and this is taken with the green filter, some light green filter, where we can see this vessels. But actually, where exactly this one vessel, I can see a thicker, and it's just not tapering, it just end at the squamocolumnar junction, but to term other vessels as abnormal is always difficult for me. And fourth picture is again with the vessels. With the abnormal vessels coming to this is the picture I'm talking. So if we look at with the acetic acid, this is how it looks like when we put acetic acid. And even punctation, if you look closely, oh no, I can put that close up on this. If we look closely, we can find that things are there somewhere here. I can't put my cursor. Yeah, this is fine punctation is there, but when we did a biopsy, it has come out to be hyperterism. Anyway, this is how we see with acetic acid. Even in the VIA test, it was identifiable. It is not only with the colposcopy, but colposcopy has shown us this punctation. So abnormal colposcopy, this is from the book which I have read in during my post-graduation day in Novak's gynecology, that 50% ESC, 20% LSIL, and 75% SSIL. This is still the same. Not much change in recent literature also, and even no publications on this because it is well established. And grading system, the purpose of this colposcopy first is that it basically directs us for the biopsy to the most abnormal appearing area. That is very much which VIA usually is little bit lagging behind. And second thing is worst area. If the grading system component is, if we apply the grading system correctly, if our assessment is not only subjective assessment, but if it comes objectively accurate, then the worst area biopsy will come. Because many of the time I have seen just CIN1 in the first biopsy, and when we do a leap biopsy, the bigger area, it comes as a CIN3 or invasive area. That's where colposcopy helps us a lot. And there's another study I just like to mention. It was done in 2006, not now, it is quite old. Single biopsy versus multiple biopsy. It was done by NCI Bethesda, published in 2006. They have done an ASCUS LSIL trials study, and at multiple places it has been done, where they have seen the single biopsy versus multiple biopsy. If our colposcopic assessment is, I'm again repeating that, it's coming accurate to the objective assessment as well. Also, not only subjective, then a single biopsy as effective as multiple biopsy, it has been found, rather than taking multiple biopsies, whether we should or not. And they have, in their discussions, they have recommended that only if we are early beginners or we are not very sure, then only go for the multiple biopsies. Otherwise, if colposcopy we are doing, always try to get the worst area, and even single biopsy will suffice you if you are using a proper biopsy forceps. That is another thing. That's why I show that biopsy forceps in the very first slide of my colposcopic talk. This is because Tisla's biopsy forceps, we have learned from our school days that it's the best which we can get biopsy specimen. So with the grading system, we need to see few things like acid-to-white area, what is the color or degree we can say, patients, I have talked about patients, margins, surface contour, and iodine uptake. Iodine uptake is always coming more or less in the last because it guides us to take a biopsy, but exactly in our assessment, it doesn't give a lot of, though in a Swedish score and British score also they have put a Google's iodine application, but it doesn't make us a lot of objective assessment. And either use Swedish score or rate index is there, and or just make it low or high grade, we have to put it. It's a Swedish score. I just like to put this chart as if we hang it in our colposcopy machine along with this IFCPC criteria, then it will make very easy for us to guide to take a biopsy, whether to take a biopsy or not, because all white lesions doesn't need biopsy if we are doing a colposcopy. If it is with a RIA, there's no doubt we can take either biopsy or retreat, but with the colposcope, it is always reserved for that reason. We need to take a biopsy. If we are doing a proper colposcopy, as in our setup colposcopy, see and treat, still we are not implementing that protocol. Like in one of the guidelines is that we can use a colposcope to see the lesion, which has been identified either by cytology or VIA positive, then treat them without biopsy. That is one thing. But even as we are fighting from the very beginning that cytology is not possible in all places of Nepal, the same thing, colposcopy is not possible to take in all places, in all health centers of Nepal. So this will help us to take a biopsy if we are doing a colposcopy. And shiny white color, this we can see in this picture, we can see a white shiny, this is called shiny. If we have to compare this with the green light, it has been seen. I was just trying to see a few of the bases. We can see 5 mosaic I can make out, but it's very less. And it's the Lugol's iodine. Iodine uptake is not there in the lesion side, but with the color, I'll come in the end how iodine color has been classified and how difficult it is to always distinguish between these different colors. So it is there. So we come to the dense color. This is the color. If we look at the first picture, we can see the color shiny white. It is white, is very white, it's milky white. But if you look in the second picture, definitely this is a dense and little bit yellowish color is there. And not to forget, it's going inside the cervical os also, which is one of the category we always term of a high grade lesion. And look at the margin. If you remember the first picture margin over here, this geographical border, I'm coming to the margin later in slides also, but we can see that it is sharp, margins are very distinct and very sharp. So this is another picture where we put Lugol's iodine, we can see the uptake, and this is for this picture. Look at the difference. These both are high-grade lesion. This has come out as a CIN2 in both the cases. But look at the difference in Lugol's iodine uptake. So it is very difficult to term it as a which yellowish iodine, mustard iodine, what we say, not taking this iodine color. That's why iodine uptake is not that reliable. Even for the subjective assessment, it doesn't give us a lot of information most of the time. The only good part is many of the time it directed, we can, even without colposcopy, it can direct us for taking a biopsy with the Lugol's iodine. Exactly. When we have seen the same area, first with the acetic acid, then when we are applying the Lugol's iodine, then we can exactly go to the same place. It is only that. With the high-grade lesion, another picture I have put over here. these two pictures, and when light was there with the green light, it was basically without acetic acid. This third picture is not the fourth one, but the third picture is, and we can see a mosaic. What we say is for the vasculature, if we have to assess the vasculature, the best thing is do it with the normal. The first thing is just assess the general assessment, then apply the normal saline and look through the green light, look for the punctation, mosaicism, whatever is there, then only apply the acetic acid to look at the regions. That is the simple procedure which has been described in colposcopy. We can see that these four pictures of different either lubals or with green lights and acetic acid applications. So vascular changes, again, I'm coming back for punctation and mosaic pattern. This is the schematic diagram I have taken from, again, Shankar Narayan 2001 developed IR manuals. I find it very informative. Two things we can see, what to call fine mosaic and what to call coarse mosaic and punctation. Yes, and this is one of the bookish thing I have just copied. And umbilicated mosaic, there's another terminology, but it's very difficult most of the time. So if you look at the lesion, this picture is from Dr. Shankar Narayan, I have copied. So this is quite good. So I'm again putting the same old picture we can see. I think I have another picture. Yes, if we look in this picture closer version, we can see in the down somewhere around 6 to 7 o'clock, it is there. This is either we can view our big one also is there and fine mosaic, both things we can see. Though this is a high-grade lesion actually when we see. Similarly, in the coarse mosaic, it is in this picture also we can see, this is from the Shankar Narayan, this is not, but this one is from Shankar Narayan manual. We can see the mosaic pattern very well. So if we zoom it, then it is more clear. Even in the first picture, now we can see clearly that tiles like structures are there, and the punctation is a fine punctation which I have mentioned in the previous slide. So it is there with this yellow, and if we zoom it, then we can see this point. This has to be seen through the green light. For the punctation, even for the mosaic, is more or less when we apply acetic acid, it comes as a prominent, but for the punctation, it is always better with the green light. So these are another three pictures. This second one, I'm trying to focus. Yeah, there we can see, this is umbilicated. If you see, it comes, I couldn't find the exact umbilicated picture. So I'm trying to focus this and keep in this big picture that somewhere here, if you see, there is in the middle, there's something is dipping inside. Umbilicated mosaic, how it appears is when the dysplasia has invaded the glands as well. So it comes, it has gone deeper in the tissue, and there's a donut type of appearance is there somewhere like this. We can see there's in between, there's a empty space, a small thin line, and covered by a elevated white area. So now talking about the margins of the lesion, as I've said, in the high-grade lesion, distinct margin, straight borders, and internal borders. I'll cover that one picture where we can see clearly the internal borders. And margins is suspicious of invasive lesions. If we call, previously we used to use it for a simple normal Ethiopian like erosion things, but now the technology has been changed. If they are rolling or peeling is there, then definitely something we have to suspicious of. In this too, just to compare the margin which I have mentioned geographical, it's an old picture. And internal border, we can see in this picture, as I have said, there's if you look, this is a darker color in this area, then this is the shiny, little bit whiter on this area. If you look this two color difference, then we can see there's another border which has been started from here, but it is going inside. So this is the inner border, what we call, and if it is, there are two lesions we can make out. One is low grade and another is high grade. Is this white is different from one place to another place, then definitely this is of high grade usually, and we have to focus our biopsy in the high grade area, not over this white shiny area. Rather than that, we should be focusing on these areas to take a biopsy. So another is rimmed gland. Basically, it's for the dipping of dysplastic cells in the endocervical crypt, what it is called. They always say it's pathocommunicable of high-grade lesions, and the cleft is surrounded by elevated white rings giving donut appearance. It's almost, usually picture gives almost a similar appearance as umbilicated mosaic. I couldn't find in my pictures, so I put one of the book picture over there, which they have shown quite nicely, but it's almost the umbilicated thing which I had shown in previous picture as well. So coming about the locations of the lesion and grading, if we give little bit of attention on this, like high-grade lesions, they are usually close to squamocolumnar junction, and they are usually going inside the os as well. What we see is not only limiting outside, it's well pointing towards us. And another is anterior lip involvement in the high-grade lesion is twice as common than the posterior lip involvement. Similarly, if lateral angles of the cervix are only involved area, then most of the time high-grade lesions doesn't go only limited to that area usually. Similarly, if the acetowhite area persists for longer time, when we put acetic acid, we applied, usually in the colposcopy, we applied for second, third time, and we assess every time we see it through the colposcope. But after stopping the application, if it fits very early, it's usually in the high-grade area. Whereas what we say is for the high-grade lesions, it appears late and it remains late actually, rather than low-grade lesion, which appears first very fast and even it goes faster. So, and similarly, large high-grade lesions, they are trying to be larger, but all these points doesn't come accurate as it is written over here. I'll show in the pictures which I come in the last. So if we talk about the density, margins, and location, if we compare this whole picture with the new picture I have shown, we can see that the margins is different. One is geographical margin, another is sharp border, then one is shiny white. It is little bit thicker white is there, not that shiny brightness is there. It is going towards the us over, it is also going, but the density over here and this is totally different, and it is covering almost the whole area where it is on the patchy lesions are there. So now coming to the iodine uptake, with all those pictures which I have put along with the acetic acid, we have seen that, though it has been described that if it is a dark brown, we say it is a normal iodine uptake is there. Then orange, yellow is columnar epithelium text, and yellow is this is pathognomic, and partial uptake, metaplasia, even partial uptake we have seen our acetate white area also, and which are come out in the histopathology as a CIN 2 or 3. So these iodine colors exactly doesn't go well with our objective assessment, though no doubt it goes with the subjective. There's no doubt we always can identify the biopsy area. And so it has been said it is less reliable as many benign as well as metaplasia, they do not take the iodine color. So with the colposcope, there are a few basics we have to remember. First thing is we can't forget that minimal reporting things, even if we are giving a printed thing to patient, usually they find those pictures very scary and they always go to another doctors, what is this? It is all these red things. But we need to write few things over there also, that acetowhite area, vessels, margins, if we can mention all these things, okay. Otherwise that minimum 4 things we have to write, which I had mentioned in the very beginning slide. So either if we can taking a biopsy decision, we are confusion, then either do a Swedish score or British index, and put it as an impression. Always we have to put as a low or high grade lesion. But there are few pictures. Now I'm coming with the colposcope, where colposcope is, I always say this is a subjective, even for me it is a subjective assessment. This first picture, it is almost some ectropion amount and nothing is there. Even in the second picture, when we applied acetic acid, hardly there is lesion is visible, though it has been magnified quite a lot of time. And if I put it more magnification, then we can see little bit of this white area is there. And when Lugal's iodine is the same, Lugal's iodine color is not at all to trust, but definitely this is not taking the Lugal iodine. It has come out as CIN3, this lesion has come out. So we always need to be very judgmental when we are doing a colposcopy. Similarly, another picture, this is a post-menopausal cervix. It looks with a few petechial hemorrhages, and when we put with the acetic acid, initially I thought this was just discharge or some, we always say post-menopausal woman, there's some whiteness is going inside, so it looked like me. This is one picture, and another, this third one is just a very angry looking cervix, but at the first impression, it was not giving much. And when I put acetic acid in the second picture, even that whiteness, which we used to look in our colposcopy diagnosis, which I had shown in the previous pictures, it is not there. In both the cases, it's very difficult. If I focus on these two pictures, now we can see. This is focusing of the picture. Actually, colposcopy has been taken with full focus. So there we can see little bit of whiteness, but still not that whiteness which we always put in our mind when there's a high-grade lesion, it will come. This is invasive cancer. It has come out to be invasive cancer in this case. And even in this case, it was microinvasion was there in this case as well. So it is very difficult. Another picture I'm covering, even it is more. This lady is a very healthy lady who has come to my clinic. This first picture, if you look at, it is just simple. There's no this epithelium bridge. Actually, my speculum has slightly touched on that side. That's why there's a bleeding. Otherwise, there's no erosion. Nothing was there. It's a very simple. Initially, I thought it's just a discoloration of the cervix. So I called her after 6 months. And her acetic acid application also, this is later on findings. But initially, it was not, no aceto-white area was there. But when on the second visit she came, there's little bit more acetic acid uptake. I feel personally there is something. Then when I took a biopsy, it has turned out to be microinvasive again. And later on, it was actually not in the biopsy. CIN3 was given in the biopsy, but I did a leaf biopsy. Looking at these pictures, I really feel something I was missing every time. So when I did a leaf biopsy, it comes out to be microinvasive. So this is this type of pictures we encounter very frequently in our clinic. This is another picture that cervix look perfectly all right, but when it turned out to be just in the acetic acid, and when the biopsy was taken, it has come out to be microinvasion. Actually, no, even in a first instance, I was about to say there's no lesion, but when we go deeper and with a little bit of uneasiness, only I took a biopsy and it has come out to be microinvasive. So these are the things that colposcopy helps us also. Colposcopy gives overconfidence also, and sometimes colposcopy misguide also. We need to be very careful. These three things we should never forget. But if we try to write few things in our colposcopy report, then definitely we are more towards the objective reporting rather than subjective reporting. So in summarizing this presentation, I'd just like to say, no doubt VIA is best till this HPV transition period. We can shift to HPV self-sampling. But again, quality assurance, either for cytology or VIA or HPV DNA should be there. And colposcopy without VIA train needs really, really more vigilance than, because all those cases, usually what I personally feel is I'm doing a lot of VIAs since 2011. So maybe that they were helping me to guide to more objective towards the colposcopy. That's how I personally feel. And definitely for our daughters, for our granddaughters, we need to advocate for HPV vaccination and screening at the national level to take it. To this, I'll conclude my presentation. Thank you very much. Any queries, questions are always welcome, even for the links which I have seen over there with the pictures. Many of the pictures I have taken from my patient client permission, and they have used by Dr. Partha Basu in his IARC Atlas also, which I have taken in one of my study with a study client. It's many pictures I have taken either from that atlas, which has been recently published from the same manual, or from my clinic photographs with my client permission, and link for the studies I have given. If anything else, anyone want to know more about that, I can always provide. Thank you very much.
Thank you, Dr. Sarita, for such a wonderful, elaborate presentation on a very important topic for Nepal and for gynecologists, for gyne-oncologists, and for healthcare providers in Nepal. Why? Because cervical cancer happens to be the commonest cancer among Nepalese women, number one. Number two, it is preventable. And as Dr. Sarita has clearly highlighted, and probably this should be a take-home message for us, that world is making an effort to eliminate this cancer. And I remember, like Dr. Sarita and myself, we've been together since medical school back in 1988-89 in IOM. There, our teachers used to say, cancer, no answer. But we are now talking about prevention. Not only that, we are talking about elimination of cervical cancer. So this today's webinar and presentation is very important for us. But the sad part is, among South Asian countries and probably among Asian countries, Nepal has the highest prevalence of cervical cancer. This I've realized through series of presentations that I've been asked to do so. And unfortunately, the death in Nepal is also among the highest in South Asia. So we need to act, as Dr. Sarita has kind of encouraged us to do so. Before I open the forum for the question and comments, I would like to acknowledge the presence of very important people who are a great source of inspiration to us. Professor Sanumayadali, we're really happy to have you in our audience as a participant. Dr. Bimla Daksab, Dr. Aruna, Geeta ma'am, our teacher, Hira madam, past president of NESOG, and of course we have Dr. Ganesh Dangal, present president of NESOG, and our treasurer, and of course Gyanat sir, who chairs NHRC and is in NESOG as well. So we would like to thank you all for being with us. And to begin the session, just to summarize and acknowledge Dr. Sarita's presentation. She has nicely enumerated the different cervical cancer screening in Nepal, and most of them are doable. And I remember while working with Dr. Sarita Didi in BPIC MCH, she used to advocate for VIA rather than Pap test, which we were doing. And in almost a decade time now, she's advocating for more for HBV DNA, which is more precise. And probably these are doable. Thank you, Dr. Sarita Ji, for highlighting this. And of course, highlighting the importance of HPV vaccination. And you've rightly shown that picture where we might have made a wrong move with screening rather than vaccination, which has been true for COVID as well, because we were focusing on a lot of tests. Now we realize vaccination is equally important. So even in cervical cancer, probably NESOG, MESON, and we, GOSON, and all of the gynecologists need to advocate for SPV vaccine to be incorporated in national immunization program. And probably that would kind of help us in preventing cervical cancer. And of course, intervention, which has been highlighted with the upcoming of several medical schools, several centers, cancer centers, probably the services for pre-invasive lesions and for invasive lesions will be available. And as Sarita Didi has highlighted, the WHO's kind of elimination targets, 90, 70, 90. Probably we will be doing well in later 90, that is intervention. And thanks a lot, like a lot of beautiful images from your gallery, very rich, which is highly appreciative, and we're thankful. So with these, I would like to open the forum for comments and for questions. I have not seen any questions in the chat box. Sheila ma'am, would you like to begin with
Maybe
comments?
they will ask by themselves question. You just
Yes.
the floor. Yeah, they can ask personally.
Yes. Probably I should be breaking the
Yes,
ice.
anyone can unmute themselves and ask.
Yeah.
I can see one question in the chat box that Kavin has asked, doesn't VIA test acid affect uptake of Lugol's iodine? Yeah, actually, Kavin, what I personally do is, if you ask me, I use Lugol's iodine very less. Though in a colposcopy, I can't give that reason, but as it is very subjective to me. But the thing is, after applying acetic acid, after 2 or 3 minutes, it almost always the effects goes off. So I'm sure it doesn't, though I haven't come across any of the studies which has said that this after application of acetic acid Lugol's iodine after this minute we should apply, but I'm sure because we always see first with assess with the acetic acid, and there always time lag is another 2-3 minutes is happening there. So with those pictures also, when we apply, we haven't given much attention to the time in between, and I haven't seen much difference in my personal opinion. If anything is there in the literature, I'm not much aware. Anyone can answer this question if anything is other than this in the literature is there.
Dr. Sarita, what do you suggest for post-menopausal lady, BIA or pap smear? What is the best?
Ma'am,
What do you suggest for the
to
floor?
my presentation,
I'm just asking for that. Just tell.
It is
Yes.
SPV DNA test is the best. If we are talking about the post-menopausal, that test will suffice. She doesn't need to come back again and again. That has been clearly mentioned, ma'am. Even with a single test of SPV DNA, if we are doing on a post-menopausal lady, and if that has come out to be negative, unless there's some conditions that if she's sexually active and her sexual partner has been changed, that is different scenario. If she's remaining with the same partner and she is post-menopausal lady, then with a single HPV DNA test, nowadays nothing has been recommended. That is the best. And no doubt, ma'am, with the cytology also, we said VIA is not at all because it always goes inside. We have seen. That's why now the age group from our 60 years, we are trying to manipulate it to 49 years. The same thing, even with recommendation all worldwide. Now we have to pull it out from 60 to 49 years because after 50 only scomocolumnar junction is very difficult to see. But in the cytology, we shouldn't forget just by taking not with a spatula, but we have to use a endocervical brush. If we are using an endocervical brush, then definitely cytology has more precision than VIA. But as you have expected, ma'am, from me is no doubt SPV DNA is the best if you ask me in one sentence. That's how I feel is.
Namaste, ma'am. I have one question, ma'am. Regarding SPV vaccination, it's been says that 9 to 13 years is the most effective age, and also till 26. But what is the age criteria for the vaccination?
Yeah, this is actually, it depends on the now what has been made is it depends on the country protocol. Okay, they have given, though in the guideline I have gone through when we are making that Gavi project also, we have gone through whatever is guidelines are available from 26. Even in some countries they have given up to 40 years female, isn't it? But it is basically how the country is going to take a program and how many coverage of, because we have clearly, the studies has clearly proven if it is given in less than 15 years of age, it has maximum efficacy. And I have shown with that study, even the single dose which has given to those 9 to 13 years old female at that time, exactly remaining in that time frame, not 15 also, 9 to 13 girls were vaccinated, it has a very good efficacy till now when comparing to 2 doses or 3 doses later on given. So what is these recommendations are basically, these are all for the country to make. And if you ask me, it is if we can give it less than 15 years girls, then definitely we'll get a maximum protection. But it doesn't mean that we should leave 25-year-old young lady who has not been sexually active. She should also get, because some kind of protection is definitely with that also it has been.
So we can vaccinate all the reproductive ages women also, is ma'am?
It is basically with her sexual activity it is related. If it is, or she is already sexually activated and the virus has already acquired inside her cervix, then there's no point, they said, because immunity we have seen with the virus. Even after vaccination, if that particular strain, though there's another school of thought is there that like if we vaccinate those females also, if other strain is already affecting her, and if 16 and 18 is not there, then oh hello baby, she's trying to get a glimpse. So that will also give some protection. But when we talk exactly about the protection of SPV vaccine, it is always recommended that she should not be ever sexually active. I'm not saying at that time sexually active, but ever sexually active woman we can vaccinate.
Okay, thank you, ma'am.
Dr. Jitendra,
Yes, ma'am.
क्वेसन छैन भनेदेखि डक्टर बराललाई भन्ने हो कि है डक्टर सरिता थ्यांक यू सो मच
हेलो डक्टर
Yes.
जितेन्द्र म एउटा क्वेसन सोधौँ है
Yes, ma'am.
Sarita
Yes,
madam,
Doctor.
thank you so much for your insightful presentation. I'm just wondering, हाम्रो गभर्मेन्टले नेशनल HPV vaccination program को लागि कतिसम्म अहिले वर्कअप गर्दैछ डाक्टर साहब?
That's very difficult. I think almost all of us are, wherever is visiting ministry on and off, Sunila. This is really, is a very also, because we all are looking for that. It should be there in the national operating, because since 2016, whenever I have a chance to go to child division, I'm always forcing them, I'm always asking them when it is coming. But the thing is, lot of other things are in between. It has come. Actually, it was supposed to be there by 2019 in the national level, but the company has stopped producing that Cervical vaccine. That also pulled us behind. It's some bureaucracy of the company, and then again we put our priority on those areas for rotavirus and pneumococcal. That also lagged behind with the SPV, and now it is in the process. Though it has gone through the Gavi application and everything has been acquired, what I understand right now is, but with this COVID, otherwise it would have been there by 2022. That's just before the COVID pandemic. It has been very common in the ministry that now we are going to get the vaccination by 2022. But again, this COVID has pulled us for I don't know how long and how we really are going to take it. It's a exact time period. I think it's very difficult to say, but some piecemeal amount, like in Bharatpur Cancer Hospital, they have started vaccinating for few girls, like 6,000, I think. They are started vaccinating. I don't know, these piecemeals will go, but we really need a national program. That's no doubt. But for that, what I personally feel is still we need to wait for some more time. That's, thank you.
Yes, thank you so much. Hopefully this GOSON will help the government in giving pressure for your vaccination. Thank you so much.
Yes, Dr. Sunila, fully agree with you. Societies like NESOG, societies like GOSON and MESON, and all of us need to advocate. And we did make a change, like our seniors, they advocated for safe abortion care, and abortion was legalized, and it was through our our professional society took the lead, and probably it's high time that we take the lead for SPV vaccine advocacy. And it is true that BP Koirala Memorial Cancer Hospital has purchased and is making available HPV vaccine in 3 districts: Chitwan, Nawalparasi, and Japa for this year. And probably government of Nepal will be extending the vaccination programs to more more districts.
Dr. Jitendra. Dr. Jitendra. म डाक्टर सुमन ताम्राकार मेडिकल हस्पिटलबाट आज गोसनले एकदम राम्रो कार्यक्रम गर्नु भएको छ। अब डाक्टर सरिताले भनिराख्नु भएको छ विगत 10 वर्षको दौरानमा यो VIA को उहाँ लागि परेर पनि उहाँ मात्र होइन मलाई पनि धेरै जानकारी छ। मेरा अग्रजहरू अथवा समकालीनहरू यो VIA मा अथवा चाहिँ सिंगल स्टेटमा धेरै लाग्नु भएको छ। तर पनि 10 वर्षको दौरानमा 8% मात्र कभरेज भइराखेको परिप्रेक्ष्यमा हाम्रो यङ कलिगहरू भनेको अहिले करेन्ट पोस्ट ग्रेजुएट स्टुडेन्टहरूलाई पनि एउटा चाहिँ क्र्यास कोर्सहरू जस्तो गर्न पाए राम्रो हुन्छ। एउटा कुरा यसमा मेरो सजेसन चाहिँ गोसनले नै लिड गरोस्। नेपालभरिमा अब BPS धरान अथवा चाहिँ पूर्वबाट अब धेरै ठाउँमा पश्चिमसम्म अब हाम्रो IMK टिचरहरू कतिपय ठाउँमा रिटायर हुनु भए पनि पश्चिम मध्यपश्चिमसम्म पुग्नु भएको छ मलाई थाहा छ। अब नयाँ इरप्टिङ अब यो कर्णाली जस्तो अथवा चाहिँ राप्ती जस्तो ठाउँमा पनि धेरै त्यहाँतिर चाहिँ एउटा प्रोभिजनहरू अथवा चाहिँ स्कोपहरू देख्छु। गोसनले अथवा नेसोकसँग पनि एउटा पार्टनरसिपमा एकपटक चाहिँ सुरुमा हाम्रो पोस्ट ग्रेजुएट स्टुडेन्टहरूलाई चाहिँ ट्रेनिङ दिने, त्यसपछि उहाँहरूलाई चाहिँ सर्टेन नम्बर चाहिँ देशभरि 18 देखि 20 वटा मेडिकल कलेज भइसकेको परिप्रेक्ष्यमा रिप्रेजेन्टेटिभ एउटा चाहिँ डाटा हामीलाई पनि थाहा हुन्छ। अनि यो VIA को हाम्रो यो हामीले सोचिराखेको एज अब एक्सपिरियन्स आफ्नो धेरै कुराहरू आफू इन्भल्भ हुँदाखेरिको मात्र एक्सपिरियन्स भन्दाखेरि अब न्यू जेनेरेसनलाई त्यो कामहरू हामीले डेलिगेट गर्दाखेरिको नयाँ च्यालेन्जहरू पनि थाहा पाउँछौँ। एउटा देशभरिको रिप्रेजेन्टेटिभ डाटा पनि पाउँछौँ। तपाईँहरूले अथवा तपाईँ भन्नाले तपाईँ हामी सबैले चाहिँ यो गोसन थ्रु अथवा चाहिँ पार्टनर नेसोकको पार्टनरसिपमा चाहिँ पोस्ट ग्रेजुएटहरूलाई मोबिलाइज गरेर अथवा चाहिँ उहाँहरूलाई चाहिँ सर्टेन टोकन अफ मनी एज अ प्राइज दिएर सर्टेन मिनिमम यति चाहिँ स्याम्पल मेडिकल कलेजमा भन्ने किसिमको गरेर गर्न पायो भनेदेखि अनि राम्रो हुन्छ कि यिनीहरू मध्येबाटै यङ कलिगहरूबाटै अनि कतिपय अब भनौँ न गाइनी कलेजमै अब आफ्नो फर्दर क्यारियर अथवा चाहिँ गर्न त्यो ग्रुपहरू पनि रेडी हुन्छ कि जस्तो लाग्छ। यो अब आजको प्रेजेन्टेसन चाहिँ एकदम राम्रो छ। यो एउटा मेरो सानो सजेसन मात्र हो। थ्याङ्क यू।
थ्याङ्क यू डाक्टर सुमन। यसमा शीला म्यामको कमेन्ट, सरिता डाक्टर साहबको कमेन्ट।
थ्याङ्क यू डाक्टर सुमन, उहाँले दिएको यो सजेसन चाहिँ इज भेरी गुड। हामीले नेसोकसँग मिलेरै गर्नुपर्ने हुन्छ है, नेसोकसँग मिलेरै डाक्टर गणेश पनि यही हुनुहुन्छ। त्यो एउटा कुरा भयो। अर्को कुरा चाहिँ मेरो एक्सपिरियन्स जस्तो कि इन्डियन गाइनोकोलोजिकल सोसाइटीले जसरी प्रेग्नेन्सीमा भ्याक्सिन लाउनै पर्छ, ल्याक्टेसनलाई भ्याक्सिन लाउनै पर्छ भनेर एउटा यस्तो गभर्मेन्टलाई प्रेसर दिएको थियो। त्यो उनीहरूको प्रेजेन्टेसनमा वेबिनारमा म पनि थिएँ कि कन्टिन्युअसली यस्तो प्रेसर दिएर दे गट थ्रु के होइन। त्यसमा चाहिँ त्यस्तै हामीले पनि मिलेर यो भ्याक्सिनेसन प्रोग्रामको लागि गभर्मेन्टलाई एउटा प्रेसर दिन सक्यो भनेदेखि मलाई लाग्छ वी सक्सिड गर्ने चान्स हाम्रो धेरै छ। एउटा जस्ट इक्जाम्पल दिन्छु। डाक्टर सरिता जब त्यो भ्याक्सिनेसन प्रोग्राम चाहिँ NNCTR ले पहिले ल्याएको थियो नि फर्स्टमा है, उसले चाहिँ केही ग्रुपलाई भ्याक्सिनेसन गरेको थियो। त्यति बेला आयन फ्रेजर पनि आउनु भएको थियो जसले यो भ्याक्सिन इन्भेन्ट गर्नुभयो। उहाँ पनि आउनु भएको थियो, उहाँसँग हाम्रो भेटघाट सबै भएको थियो। दे आर गोइङ टु भुटान होइन, भुटान जान लाग्नु भएको थियो। अनि भुटानमा गएर त्यही भुटानमा गएर उहाँहरूले चाहिँ पहिले फ्री अफ कस्ट दिनुभयो भ्याक्सिन, पछि उनीहरूले बाई गर्दाखेरि 97-95% भ्याक्सिनेसन अलमोस्ट भयो उनीहरूको। त्यही नेपालमा चाहिँ हामीले भ्याक्सिनेसन गर्न सकेनौँ होइन। एउटा हाम्रो फेलियर के भने हामीले जुन 8% मात्रै अहिलेसम्म हामीले गर्न सकेछौँ स्क्रिनिङ प्रोग्राम भनेपछि कतै न कतै अब केही न केही ल्याकिङ त छ। भनेपछि हामी मिलेर यदि गोसन नेसोक मेसोन मिलेर यदि गभर्मेन्टलाई प्रेसर गर्यौँ भने मेबी हामी चाहिँ सक्सेस हुन सक्छौँ जस्तो मलाई लाग्छ। यो कसरी गर्ने भनेर हामी चाहिँ डिस्कस गरेर एउटा प्लेटफर्ममा आएर प्रोग्राम अगाडि बढाउनु पर्ला जस्तो लाग्छ मलाई।
म एकचोटि कुराहरू
हजुर
हेलो
हजुर डाक्टर सर
म के भन्छ हजुर डाक्टर सरिता तपाईको प्रेजेन्टेसन एकदमै राम्रो छ जुन तपाईले एभ्री टाइम यो कल्पोस्कोपीकोमा जानेर यो सबैकोमा त्यो डे टु डे हामीले फेस गरिराखेको चिज तपाईले भन्नुभयो हैन जुन हिसाबले कहाँनेर डिफिकल्टी सबैको आफ्नो आफ्नो छ जस्तै त्यो प्यापको एचपीभी को मतलब तर जे भए पनि तपाईले भने जस्तै गरिकन ट्रेन भिआईले नि सबभन्दा बढी तपाईले भने 70% त हामीले नै गर्छौं तर अब त्यो चाहिँ गर्दाखेरि सिक्ने नै हो त्यो चाहिँ सबै सब्जेक्टिभ हो मलाई अर्को लागेको जुन अहिले त अब WHO ले पनि आइसकेको छ नि त एसबीबी कोले पनि धेरै नै आउने जस्तै अब अहिले चाहिँ मैले देखेको चाहिँ यति ठाउँमा पीसीआर मेसिनहरु राखेको छ कोभिड को लागि भनेर सबैजनाले त्यो जुन यो डीएनए एक्सट्र्याक्टको सबै अहिले ठाउँमा यति धेरै पीसीआर मेसिन छ अब कोभिड त मुस्किलले 1-2 वर्षमा जाला नि भनेपछि त्यो मेसिन छ म्यान पावर छ सबै छ तपाईहरुले जुन गभर्नमेन्टमा जाँदाखेरि त्यो मेसिनकोमा चाहिँ जुन त भएछ नि यो एसबीभी को गर्नलाई एटलिस्ट गभर्नमेन्टलाई किनभने मेरो विचारमा गभर्नमेन्टको मान्छेहरुलाई त्यो आइडिया छैन होला कि त्यही मेसिनबाट यो सबै एसपीभी हरु गर्न सकिन्छ भन्ने कुरा नै आइडिया छैन होला कि गभर्नमेन्टकोमा एटलिस्ट गभर्नमेन्टमा यो कुरा पुर्याउन सक्यो भने एटलिस्ट कोभिड सकेपछि चाहिँ हामीले सबैतिर किनभने अहिले त यति ठाउँमा छ के यो के रे मेसिनहरु पीसीआर मेसिनहरु भएकोले सेम त्यहीबाटै हो किनभने स्याम्पल लिने तरिका डीएनए एक्सट्र्याक्सन सबै भएकोले चाहिँ सायद हामीले यसलाई कन्टिन्यू गर्न सक्छौं कि स्क्रिनिङको अझै बढी कभरेजहरु गर्न सक्छौं कि भनेर हामीले गभर्नमेन्टलाई के गर्न सक्छौं कि भनेर
That's a very good suggestion, Dr. Anju. यो विषयमा कुरा सकेछ त्यति धेरै मलाई लाग्छ अनअवेयर हुनुहुन्न हैन हाम्रो जुन तर त्यही हो कि एसपीभी बेस्ड च्यानललाई अहिले फेरि एउटा हामीले बिर्सिनु चाहिँ के हुँदैन भने यी मेसिनको एउटा उ चाहिँ के रहेछ भने त एउटा पैसामा आउँछ तर मेन चाहिँ रिएजेन्ट ल्याउने बेलामा एकदम धेरै त्यसमा हुन्छ हैन गभर्नमेन्टले अफोर्ड गर्न सक्ने नसक्ने र मेन चाहिँ अहिले त्यो कस्ट बियर गभर्नमेन्ट रेडी छ कि छैन हैन कतिवटा पीसीआर बेस्डको मैले चिने जानेकैसँग कुरा गर्दाखेरि हाम्रो त चिपेस्ट 6500 पर्छ एउटालाई भनिरहेछ हैन अनि त्यो स्क्रिनिङ टेस्टमा फेरि म अझ अलि बढी यो पब्लिक हेल्थको उसमा अनि एक हिसाबले जहाँ 6500 फर वान फिमेल खर्च गरेर हामी स्क्रिनिङ गर्न अझै कन्ट्री सक्षम छ कि छैन त मैले देखाएको कस्ट क्याल्कुलेसन त त्यसमा जाँदैन हैन त्यो त यसरमा त्यति बेलाको उनीहरुको हिसाबले पनि म्याक्सिमम $15 to $20 नै क्याल्कुलेट गरेको थियो कि त्यो टाइममा पनि लिटरेचर देखायो कि त्यो फिटनेसको देखाएकोमा 22 एउटा उनीहरुको एउटा सर्टेन थोरै उसमा चाहिँ $30 सम्म रहेछ तर त्योभन्दा माथिमा छैन हैन उनीहरुको जुन प्रोजेक्सन निकालेको पनि भनेपछि हामीले अहिले अब यो मेसिनहरुको एउटा हैन गर्न त त्यही नै हो अहिले इन्करेज पनि त्यही हामी सबै कुरा पनि त्यही गरिरहेका छौं यी त्यसै थन्किनु दिनु भन्दा जहाँ छ नि त्यसलाई एसबीबी टेस्टमा युटिलाइज गरौँ भनेर मेन चाहिँ सबै कन्ट्रीकोमा एउटा त त्यसमा त्यो पीसीआर टेस्टमा उनीहरुसँग एसबीबी को रिएजेन्ट छ कि छैन त्यसमा फरक पर्ने रहेछ एकैचोटि यो कोभिडले गर्दाखेरि सडनली कम्पनीहरूले आफ्नो त्यो मात्रै अब उनीहरूले पछि भित्र हाम्रो रिक्वेस्टमा उत्पादन गर्ने हो त्यो भएर त्यसको भाउमा पनि मनपरी नै हुँदो रहेछ के मात्रै दोष दिन पनि कति ठाउँमा चाहिँ किन मिल्दैन भने त्यो अचेत नसक्ने भन्दा पनि माथिको लेभलमा पुग्छ तर यो सजेसन इज भेरी मच राइट एन्ड आई एम टकिङ द सेम थिङ सेम लाइन इभन म त एक्सपर्टसँग पनि इभन मैले कम्पनीको एक्सपर्टको सेम मेसिन हो हामी जुन डीएनए गर्न सक्छौँ हैन इट्स द सेम जुन त्यो त आजभन्दा 5 वर्ष 6 वर्ष अगाडि नै नेपालमा 104 वटा मेसिन आइसकेको थियो यो जुन tuberculosis तर सेम we can use for the SPV DNA भन्दाखेरि उनीहरुको पनि still the reagent cost is on the higher side के त्यसले गर्दाखेरि हामी यो इभन म अहिले गभर्नमेन्टलाई गर्नलाई पनि लेट्स सी एकदम मिनिमम कस्टमा चाहिँ कतिमा हुन्छ भनेर बस्न खोजेर हेर्न त जुन मैले सेन्टरमा राख्न खोज्दाखेरि पनि इट्स कमिङ अन द भेरी हायर साइड जुन चाहिँ गभर्नमेन्टलाई इम्प्लिमेन्ट गरिहाल भनेर भन्नलाई त अल दिस अहिले त फेरि यो पेन्डेमिकको बेलामा अहिले हामी should be quiet जस्तो लाग्छ I don't think this corona is easily but anyway those medicines can be easily utilized as you have suggested we are also thinking of the same line हैन र गभर्नमेन्टमा पनि कुरा the family welfare division को मिटिङमा बारम्बार यो निस्किरहेछ के after this COVID pandemic.
त्यो त अहिले तर
Thank you.
तपाईले भन्नु भएको
Thank you, Dr. Sarita and Dr. Anju. probably this is a new way forward for us to think about this precision test, no doubt, and probably we should use this opportunity and resources in future. Of course, it's going to be a very interactive program, and I know like we have so much of queries, and we have our experts who would be happy to answer us, but due to time limitation, we can always communicate with each other. And probably this is not the end. Probably we call it a beginning, and probably GOSON would be happy to organize, GOSON, NESOG, and MESON would be happy to organize such webinars, such interactive meetings. So taking the time limitation into consideration, I would like to invite our academic partners, Asian Pharmaceuticals, without whom this session
Dr.
would
Baral,
not have been.
Baral.
त्यसपछि to invite Mr. Dipesh Pradhan, representing Asian Pharmaceuticals, to deliver his message.
Thank you, Dr. Jitendra. Thank you, Sila ma'am, and all the doctors, Dr. Baral, Sarita ma'am, and all the doctors. We are very much proud to be associated with this kind of academic activities of GOSON. And thank you once again for the opportunity what you have provided to us. And always thanking you for your wholehearted kind support for our products, towards our products. Especially, again, काम त गर्नै पर्यो हैन, अलिकति just reminder फेरि सधैँ हामी भनिरहन्छौँ हाम्रो मेन प्रोडक्ट तपाईहरुको लागि IROX को लागि स्पेशली रहेछ IROX. And again, we have just introduced Gemini as granicertin tablet as well as in syrup. So once again, we'd like to thank you all for your kind participation, and we hope this kind of association in future also. So thank you once again.
Thank you, Dipesh, in future also.
Thank you, Dipesh, and I think यो वेबिनारको आफ्नै महत्त्व छ. हामी यति धेरै, like I think we recorded up to 78, almost 80 participants.
Yep. Which almost 80.
So we are distinction holders, I would say.
Yes,
80%. So यो इभेन्टको मेमोरीलाई क्याप्चर गर्न सबैले आफ्नो भिडियो अन गरिदिनु भयो भने अझ राम्रो हुन्थ्यो. And then I would like to kindly invite Professor Gyannath Baral sir to deliver his message and vote of thanks. Baral sir.
Excuse me, सबैले क्यामेरा अन गरिदिनु होला, म स्क्रिनशट लिइरहेको छु पिक्चर्स. आफ्नो क्यामेरा प्लिज अन गरिदिनु होला.
Thank you, Dr. Jitendra. This is a great opportunity for everyone to participate in this very informative program that are delivered by our senior, our colleague, Dr. Sarita. She has become very senior, and she's contributing a lot for the cervical cancer screening and all training programs, and professionally and from the institutional. And this is a very good and informative. I think everyone is delighted with it. And she has delivered all real-time pictures. Those galleries are very good, informative as well. And we're expecting such type of programs, such type of information from her always. And we will be happy to be with us time and again. And it was very good. And thank you very much for the deliberation of such a good program. And I thank you all participants. I counted it was 77 altogether at one point of time. And it means we all are so much of enthusiastic to listen her presentation. It was very good, and everyone is appreciating it. And we expect like this. And there are certain issues raised by our participants and our speaker that we have not been doing well on the vaccination program or screening program, like we had one example with the Bhutan as well. But it depends on the commitment from the institution. Institutional commitment, and institutional means it could be the political from the government and the professional as well. So if you do it, we can conquer it, and we will not be behind the Bhutan. We can do it, but we should have institutional commitment from politics and profession as well. And our target that it was set by WHO, like 90, 70, 90, I think we have to go for that. And that would be the guideline for us as well. And this program, this presentation had highlighted everything that is beneficial for all colleagues. I think some residents were there, and our new gynecologists were there, and it was very helpful for us. And with Dr. Sarita was the center of the program today. I think everyone is appreciating it. And it would not have been successful without her. And for the logistic parts, Asian Pharmaceutical is always memorable for us. And this is Asian Pharmaceutical is always assisting even in the NASOC and GOSON now. We look forward to their contribution in the future again, and they are very happy to be with us all the time. And I thank you all our seniors who have been presenting and who have been present in this webinar, and our all colleagues. And thank you very much. And we'll be we are very much delighted because of our all GOSON members, Mason members, and NASOC members, and other new gynecologists as well. Thank you very much. And we'll be looking for your presence in future presentation, future CMEs, and future case presentations, and other seminars and workshops as well. Thank you very much on behalf of GOSON. Thank you.
Conclude पनि गरौँ न अब.
हजुर, शिला म्याम हजुरले कन्क्लुड गरिदिनुहुन्छ.
Thank you, Dr. Sarita, for your wonderful presentation. And in future, also you'll be with us for any presentation and for any help to the GOSON. And I would like to thank all the participants and Dr. Jitendra, Dr. Baral, my seniors, Dr. Ganesh, to make this event, and Dipesh Ji, Asian Pharmaceuticals Company. He has so kindly and nicely supported to conduct this program. And really, from my heart, I would like to thanks to Asian Pharmaceuticals Company. And thank you so much for everyone who has contributed and participated in this program. Thank you very much. Thank you so much. Yes. Arun? Bye.
Closer.
Thank
you.
Bye.
Bye.
Bye. Thank you so much.
Wishing everyone good health and safety.
For this patience and giving me so much of love and this thing attention.
Sarita, मैले फर्म पठाएको छु.
हजुर.
मैले फर्म पठाएको छु, भरेर पठाउनु पर्छ. है त.
Bye bye.
Good night. Good night.
Good night.
सबैलाई.
Shall I end this meeting?
Yeah.
नमस्ते. Leave गरौँ meeting.